share my screen. Yeah, so what I would like to do today is normally I give talks actually more about AI and machine learning and building AI models. But today I would like to talk about the enabling infrastructure and how we learned actually from the COVID experience, the quite the struggle that is needed in order to build the infrastructure for the proper development and validation of AI algorithms. I actually think the situation probably in Israel is one of the best in the world in terms of being able to learn from health data. Actually, I have to admit we are struggling, but we're stepping up our efforts there. And I would like to explain to you what we've learned and what we're doing. So we all know that, of course, everyone is talking about deep learning in many aspects of society because of the breakthrough in computer vision. But it's good to realize where the breakthrough came from. And the breakthrough had to do with having access to large amount of data, the proper technology, of course, and an open aspect of sharing data. And I think those are the aspects that we're not so good at in the medical domain, and therefore we see it sometimes harder to really make an impact with AI in the health domain if we compare it to other applications. So my main question and the reason I got involved not only in AI research but also in data infrastructures to be able to promote AI research was the question, can we utilize the enormous strength of AI technology not only for computer vision tasks but really also to develop AI models that have really relevant clinical outcomes, that we can use imaging data combined with other kinds of information in order to assess the status of a disease, to predict the outcome of a treatment, and in such a way really improve healthcare. And again, I think it's not so trivial to do the same in the medical field as in the computer vision field, because if you look at the Imagenet statistics, just the pure amount of data that is available in the open source way of thinking, it has really made this to a huge success. This didn't happen overnight, the success of AI in computer vision. It was because of many years of people making competitions, having labeled data, and really creating an infrastructure for innovation. So I think that's what we also would like to do in the health domain. And it's very, very challenging because data are scattered. There's a lot of heterogeneity in the data. There's a lot of reasons because they are personal data that we have to be careful about the data. So it really requires an effort by many and a strategic effort in order to build a health data infrastructure, which is going to be an ecosystem for innovation in AI. So that's what Health AI is. So Health AI stands for Health Research Infrastructure. And really the vision of Health AI is in order is the idea to build an ecosystem in which the data can be reused for research and innovation. And one of the main reuses will be developing and implementing AI models in health. So the Netherlands is a small country. We have, for example, we have 7 university medical centers. They have a regional function, so they link to other hospitals. So the network we want to build is a hub and node network. And the 3 main activities that we have in the hub and node network is one, to address all the issues, ethical and legal, with respect to the reuse of data. The second is building the actual infrastructure, the federated infrastructure, enabling people to search data, to request them, and have a data governance structure in place to know who can use the data for which purpose. And then a portal that is actually the one-stop shop for users. And users can be academic institutions, but should also be industry. And they will have one portal in order to have all their questions related to the reuse of health data. So this slide, I apologize, there's some Dutch in it, but it's actually just to show the concept that we've built. It's sort of the first proof of principle implementation that we made, and we made it because of COVID. So what we realized very soon when the pandemic started is that we wanted to learn from data, and that many people wanted to start observational studies, but that everybody started their own individual data collection initiatives. and patients were often very ill, and we needed much more of a structured effort there. So between the university medical centers, we then agreed on certain standards, what data that should be collected, and we mapped everything to a common data model. And using the common data model, we could fill a catalog such that from the catalog you could search and request for the data. And interestingly, this looks like a trivial effort, and we wanted to get it up to speed. And only because of the pressure of COVID, we could make some steps. But actually, it was a hard work, and there was a lot of tough battles to fight. The first thing we realized, the consent was an issue. Everywhere people were asking in different ways whether data could be reused for research. Sometimes consent was not available. There was an opt-out because of the pandemic. Other institutions asked for a consent, but the consent could be different. And it's very difficult to group data together in a database and make them available for research if there's not a harmonized consent in place. So we realized this is really a condition sine qua non. We have to get our act together, and also in the future ensure that we have much more harmonized procedures, how we can ask for consent of patients, whether their data can be reused for research and innovation. Second, heterogeneity was bad, even if if people were using the same WHO standards to collect data. So that was really something very difficult. The third thing is everyone wants to keep control of their own local data. Everyone has security officers, etc. in place. And if you have a federated network, in order to come to documents that everyone agrees on, is a hell and is a pain. So also there we see a lot of work needs to be done, and the governance over multiple institutions needs to be made in place. Finally, what we struggled with a lot, we were eventually quite successful in bringing all the data of a patient collected within one hospital, making those available. But if there were data of that patient in other places, data linkage is a problem, because in our, according to our laws, we cannot link to the main citizen identification number, which makes it difficult to link data. So, so what we're doing now and what we're building in response is first, we make blueprints of data platforms in the region, where we make agreements on how to store data. And we're talking about both the clinical data, imaging data, but also lab data, including imaging, genomics data, omics data, genetic data. So on top of that, we built this data discovery platform and the governance to request the data and get the data. And finally, an analysis environment in which either data that are requested are sent to a research environment where people can work on the data, or we provide access to data in a federated fashion. And we built this based on a number of use cases, and COVID is our first use case, but we're building multiple of these use cases. So here you see what we eventually would like to establish is that all the hospitals in the Netherlands adhere to the same data harmonization standards, and we would like to make that as much part of the primary processes in the hospital, such that in the clinical routine already data are collected such that that's easy to put them in the agreed formats, such that you adhere to the standards. And then from that data platform, all the research, whether it's sending data to national registries of the Cancer Foundation or the Heart Foundation, or whether it's to send it to our catalog in order to search data for research and innovation and AI research, basically you only store the data once. We call that a fair data station, and that fair data station is the basis in order to send the data for reuse, which could also be in international collaborations. So for the data governance, the whole structure is worked out with a data access committee. So we work with a national data access committee that reviews the requests that are made. And locally, there is only a check on whether the consent is sufficient for the data to be reused. So this is an important structure to build on top of a federated network for a federated network to work. And then finally, the final stage is once you've requested the data from multiple institutions, you want to analyze them. We have a digital research environment. Basically, that is an environment to which the data can be shipped, and you have computational resources, GPU, CPU, that you can scale up depending on your usage. And the data then really needs to be made fair. Software can be sent to the local sites to perform a local analysis. And then you can think of federated analysis or federated learning. So we think it's quite an effort. I really personally underestimated how much of the work here is related to data transfer agreements, governance, legal aspects, etc. Not so much the technology part. So really the challenge is much more in consent and data linkage and data usage and in data stewardship. But I really feel it's an effort we need to take together, because on my other side, the actual work we do with the data, we see that there's so much power in better diagnostic and prognostic algorithms if we collect data. And our overall vision from Health AI is really to, based on this network, link different resources such that we track patients and actually citizens over time. So we collect data over a lifetime. And having this federated infrastructure, we want to be able to address multiple questions with AI methodology in order to gain new insights into how some people age healthy, others develop disease. We want to better understand risk factors, and we want to have more insights that will help us to take a much more proactive role to a healthy society. So I think what we've learned, and for this COVID was the excellent use case. In order for AI to make an impact, we need to copy what has been done in other domains, and we have to have better access to data. And this is quite an effort. We really need to put energy behind it to build it. Then the next steps, I think, to make this successful is to learn from the other aspect from computer vision, is that this concept of challenges and open data in which multiple people can compete. For sure, if we have the data available and people can compete, we will bring the best of the current technology to relevant clinical problems. And this requires not the argument of whether AI is going to replace the clinicians or not. Actually, a lot of the success of this endeavor will mean that in clinical practice and clinical research, the data will be made ready for AI, and the right clinical questions will have to be asked. So this really requires a structure of co-creation in which the different people from different disciplines work together. And with that, I would like to thank you for your attention. I think I'll stop the share now. If there are questions, I'm happy to.
Yeah, thank you. Thank you so much for this extremely important topic. We all share issues of AI and the data related to that. I have a few questions. I'll start with one, which is, what's the timeline that you see going forward in the goals that you're setting forward to yourself? What are we talking about?
I think we want to have first implementations within a year, but I think they're going to be rather narrow within a specific domain and with a limited number of hospitals and with not the depth of the data. If I look at COVID, we started with the clinical data and with the university medical centers, and we're now adding the imaging data. After that, we want to link to the virology data, and next to the university medical centers, we want to add the general hospitals in the Netherlands. So that's the way we want to work, working with act fast, try to build something that works, show that it works, and then either it works or it fails. If it works, then try to expand it and scale fast. But there's multiple dimensions to scale: the number of institutes that you link, the depth of the data, or the type of diseases. So in that sense, there's a lot of work. So a lot in the beginning, but it will take years to really come close to the horizon in which we use all data.
Definitely agree.
Yeah.
Let me read another question that came in. How do you assure the standardization of the data across different medical fields and different end nodes, the centers?
Yeah, it's very difficult. So in the Netherlands, it's relatively small, but still we want to also share data across boundaries. So I think we have to adhere to certain international standards. And one thing for me, what is for sure, we have to adhere, for example, for the clinical data, especially the data that do not come out of machines, we have to be able to map to some common data models. And there's a number of efforts. There's the Odyssey community that has a common data model. There's quite a lot of standardization work going on around the FHIR communication standards. And I think different medical domains need to adhere to standards and models and make agreements, and not necessarily one model, but at least be interoperable with certain models, because otherwise, reuse is
we could talk for a long time. This is probably just we should have a whole day of discussions on this. But I have to finish with one specific question. Are you going to make this infrastructure and data available to people outside of the Netherlands?
Yes, in principle, yes. But we are not the party that is going to decide who's going to be able to have the data. We're going to provide the interface and request, and in the end, it's still the data owners, the hospitals, etc., that are going to have to indicate who is going to use. So I hope so. I hope we're going to be so open as possible. But as Health RI, we are not the owners of the data. We connect and we make the interface, and it's still the institutions, or perhaps at some point the patients, who is going to decide who is going to be able to access the data. But I hope it's going to be as open as possible.